This video will discuss interpretation of arterial blood gases. The learning outcomes are listed here, but we'll briefly be overviewing the pathophysiology of ABGs and then discuss how to interpret arterial blood gases by talking about mixed, uncompensated, and partially compensated, and fully compensated arterial blood gas disturbances. So let's briefly review what creates an acidic environment and what creates an alkaline or basic environment. Now, whether that environment is being created due to a problem or a disturbance, or whether that environment's being created as compensation, certain things will line up under acidic or acidosis, and others will be associated with basic or alkalosis. And remember, we're looking at the pH of the blood, not just pH in general. Normally, 7 would be neutral, but when we talk about blood, remember in these ABGs, we're drawing blood, 7.35 to 7.45 is actually normal, and that really perfect midpoint is actually 7.4. So let's look at these in a little more depth, starting with acidosis. What could cause someone's blood to be acidic? And when we divide them into two pretty broad categories, respiratory and metabolic, we can see two broad categories for someone's blood becoming acidic. The respiratory reasons are fairly straightforward. They all relate to hypoventilation or ineffective ventilation. Someone's not breathing effectively. They aren't moving air in and out of their lungs effectively. And if you think about it, there are a lot of ways that someone cannot be effective in moving air in and out of their lungs. They could have a head injury or a drug that has reduced their respiratory drive. They could have physical trauma to their chest, or maybe they're just too exhausted to move their lungs effectively. They could have issues with getting those respiratory muscles to work, maybe due to paralysis from a spinal cord injury. Or it could be starting from the top of their airway, where the patient is not ventilating effectively because their airway is closing, like you might see in anaphylaxis. So all of those are just examples of ways someone could hypoventilate, which could cause that CO2 retention, which would cause respiratory acidosis. Now, looking at the metabolic side of things, metabolic causes of acidosis would be problems that either cause too much acid buildup or acid retention, and frankly, that's the more common reason we see metabolic acidosis, but the other reason could be that we have base loss, or that more acid is left in the body causing metabolic acidosis. So for the acid buildup, we might see acid buildup if the kidneys are not excreting acids effectively, like what we see in renal failure, or even if someone consumes too much of something acidic, like acetylsalicylic acid or aspirin overdose. We also very commonly see metabolic acidosis in states of shock or tissue hypoperfusion, when tissues don't get the blood that they need, and therefore they don't get the oxygen that they need. Those tissues and those cells switch into anaerobic metabolism, and this causes lactic acid buildup. Now, an example of base loss that leads to metabolic acidosis is something like diarrhea. So stool is very alkaline, so when a patient loses excessive amounts of stool, they're losing excessive amounts of base or alkaline materials, and what is left behind? Too much acid. So we see metabolic acidosis in diarrhea. Now looking at the other end of the spectrum, alkalosis. What would cause the pH to go above 7.45? Well, it's essentially the opposite. When we look at our two categories of causes, respiratory and metabolic, in respiratory, instead of hypoventilation or ineffective ventilation, which caused acidosis, we're now seeing hyperventilation or overly effective ventilation. Imagine someone who is breathing very deep and fast. A lot of CO2 is leaving their body. They're breathing it out. So the actual CO2 levels in their arterial blood when you draw their ABG are low. Lower CO2 leads to alkalosis. And you can see here there's a lot of reasons patients might hyperventilate that are pretty straightforward. Things like anxiety or labor, or even being at high altitudes where there isn't enough oxygen, we tend to breathe deeper and faster. But one that can be kind of confusing is sometimes when a patient is in the early stages of, let's say, pneumonia. Imagine a relatively healthy patient that now gets pneumonia, and this patient has some pretty good reserves. They have good strength, but their body is sensing something's wrong. Now, if, and this is a big if, a patient is strong enough, they might be able to breathe deep and even hyper effectively early on in a relatively slowly progressing respiratory problem. Early on, they're breathing deep and fast because they sense something is wrong and they're trying to help themselves. This could lead to respiratory alkalosis. So just keep in mind, eventually that patient might, and often does if the pneumonia keeps progressing, they might get really tired of this deep, fast, hyper-effective breathing. And this could lead to fatigue and switch to hypoventilation. And as you recall, switching to hypoventilation would mean switching to acidosis. So this concept is a little tricky for some to grasp, but just imagine a patient, for whatever reason, who breathes too deep and fast is hyperventilating, and hyperventilating can lead to respiratory alkalosis. Now onto metabolic causes. So if we flip what we said before about acidosis and metabolic acidosis, now we're looking at metabolic alkalosis. So instead of acid buildup, we're looking at reasons for acid loss. And instead of base loss, we're looking at reasons for base retention. So where do we keep a lot of acid in our bodies? Well, in our stomachs. So a patient who is losing a lot of stomach acid, whether it's from vomiting or from nasogastric tube pumping stomach acid out, both of these are causes for loss of acid. Now also potassium wasting diuretics like loop and thiazide diuretics, those can cause hydrogen ion loss. And remember, hydrogen ion loss is essentially acid loss. Now just some background, this happens as a result of activation of the RAS system, which activates aldosterone. And aldosterone leads to sodium reabsorption, and that sodium reabsorption is exchanged for potassium and hydrogen ion loss. So that explains why our loop and thiazide diuretics can cause metabolic alkalosis. Now, reasons for base retention causing metabolic alkalosis, obviously overconsumption of alkaline substances like antacids would cause base excess, but also patients who receive massive blood transfusions are at risk for metabolic alkalosis. And the reason behind that is because blood transfusions are administered with something called citrate, and that's used as an anticoagulant. And citrate, when it's in the body, it's actually converted to bicarbonate in the liver. So now we have excess bicarbonate, excess base, which would be metabolic alkalosis. So that was a lot to take in, but now we can see how certain things might line up under acidosis or alkalosis. And this might help you summarize what we just talked about, and it also gets into how we might label certain things or numbers in the ABG when we're trying to figure out what's going on with our patients. So looking at the acidic side of things, a pH less than 7.35 is acidic, labeled as acid. Also, if a patient retains too much CO2, they have more building blocks for carbonic acid, which can create an acidic environment, acid. Now, how do we retain CO2? Well, we don't breathe it off effectively, so hypoventilation is also associated with acidosis. Looking at the metabolic side of things, not having enough base will create an acidic environment. So our normal bicarbonate levels, remember, are 22 to 26. So a low bicarbonate, or less than 22, is also consistent with an acidic environment, labeled as acid. How might that bicarbonate be lowered? Well, if our kidneys are excreting it all too much, then we will have lower serum bicarbonate levels. And also, if our kidneys are retaining too much hydrogen ion, remember pH is affected by hydrogen ions, in that more hydrogen ions equates to acidosis and fewer hydrogen ions equates to alkalosis. So if our kidneys are retaining hydrogen ion rather than urinating it out, that's also consistent with acidosis. So those are all of the acid things. We would call those acidosis or label them as acid. Now, what about alkalosis or bases? Well, the opposite concepts are true here. So a pH greater than 7.45 is consistent with alkalosis, or not enough CO2 in the body, and that will produce alkalosis, labeled as a base. And how do we end up with not enough CO2 in the body? Well, we blew it off. We hyperventilated. Too much base or too much bicarbonate will also be consistent with alkalosis. So a bicarbonate of greater than the high end of normal, so greater than 26, will be consistent with alkalosis, and we can label it as base. And if we do not have enough hydrogen ion in the blood because the kidneys are excreting it, or if we have too much bicarbonate in the blood because our kidneys are retaining it, both of those will lead to alkalosis. So here's just another reminder of our normal values for ABGs. It's essential to memorize these so that you can more easily interpret an arterial blood gas. Keep in mind, it is critical to be aware of the PaO2 and the SaO2 to provide appropriate nursing care for our patients, but these numbers are not essential in interpreting an ABG imbalance. However, it can be helpful to see these just to help you understand the bigger clinical picture. So just as a heads up, you'll often be given an ABG to interpret and only have a pH, CO2, and bicarbonate to make that assessment. So looking at the premise of sometimes a finding or a number is abnormal because it's the result of a problem or the disturbance, Or sometimes a number is abnormal because it's trying to help out or it's trying to compensate. We'll get into the part of where you figure out which is which, but let's discuss first. So a little reminder of what could be abnormal. Well, our pH could be abnormal, our carbon dioxide could be abnormal, our bicarbonate could be abnormal, respiratory rate could be abnormal. Now, the why it's abnormal is what can become a little confusing. So in order to determine whether a value, whether a number is abnormal because it's part of the problem or part of the disturbance, we would look at the core proof of the problem, and that's the pH. Really critical to remember that. So if the pH is abnormal, let's say it's acidic, it's 7.3, for example, whatever is trending with the pH, let's say an acidic CO2 or a high CO2, that correlates. That's part of the problem. Now, also, if the pH is abnormal, whatever is the opposite of the pH, let's say my pH is acidic, but my CO2 is now low or basic or alkaline, that low CO2 is trying to correct or trying to compensate, trying to help. So this is a really important concept to understand, that when things match the pH, that is going to be part of the problem because the pH is the problem. And when things are opposite of the pH, they're trying to correct the pH or they're trying to pull it in the other direction. So just remember, whatever is normal is basically not doing anything at all. So it's not causing the problem and it's not compensating for the problem. So now that we understand a little bit about what's going on in an ABG, let's walk through some steps for how to interpret them. Keep in mind, there are a lot of different strategies, and you may come across other strategies to interpret ABGs. This is just one very logical way to work through it. So the first step to do when you are getting an ABG and you want to interpret it is label each number. This is why it's important to know the normal values for pH, bicarbonate, and CO2. Each number is going to be labeled as either acid, base, or normal. Then next, once all the numbers have been labeled, look at the pH specifically. Remember, the pH is the problem. So what is it labeled? If you labeled it acid, then you already know part of your final answer to this ABG. The patient has something acidosis. If you labeled it base, if you labeled that pH base, you know that we have something alkalosis. Whether the pH is alkaline or acidotic, that tells us whether the entire ABG is alkaline or acidotic. So next, we need to figure out why we have an acidic or a basic pH. Who is at fault? What was the cause of this problem that we have? And how do we figure that out? Well, look at those labels again. Which of the two values, CO2 or bicarbonate, which of those match the pH? For example, if the pH was labeled acid, then I'm looking to see which of the other two numbers is labeled acid. If the pH is base, then I'm looking to see which of the other two numbers is labeled base. So whichever one matches is at fault, or is the disturbance in a sense. Now, if the CO2 is labeled acid and the pH is labeled acid, I know that CO2 relates to my respiratory system. So we have respiratory acidosis. And if the bicarbonate was labeled acid and the pH was labeled acid, then I know bicarbonate relates to metabolic, so we have metabolic acidosis. So I no longer have something acidosis, I have metabolic acidosis, or I have respiratory acidosis. Now next, we want to see if the system that wasn't causing the disturbance, if that number didn't match, was it trying to help out? Is there any compensation? And remember, sometimes there's no compensation at all. But how do we know? Well, were there any numbers that were labeled opposite of the pH? So think of those as trying to pull the pH back in the other direction, or pull it back to normal. So for example, if the pH was labeled acid and the CO2 was labeled acid, so I know I have respiratory acidosis, I'm going to look at the remaining number, which would be my bicarbonate. Was that labeled base? And if it was labeled base, then now I have proof that we have compensation. If it was labeled as normal, then I don't have any compensation at all. And it wasn't part of the problem and it wasn't trying to help, it just didn't do anything, so it's uncompensated. So last, be sure to keep in mind that, as mentioned before, it's always important to see if the patient is oxygenating well. So that PaO2 and SaO2, they're not going to affect our acid or base balance directly. They're not going to be labeled even as acid or base. They're just going to be labeled as high, low, or normal. And this label is, again, not going to change our ABG disturbance, what our final answer is, but it will be very important to know and really add more to that clinical picture of how we're going to take care of this patient who has this ABG. All right, so let's take this a little bit further with some examples. Remember, the pH will always tell us what the overall problem is. If the pH is less than 7.35, we are in some kind of acidosis. And then if the pH is above 7.45, we are in some kind of alkalosis. And then we're going to be looking at the rest of the ABG to determine what caused that acidosis or alkalosis and if there was any compensation. So using this example here, remember first I'm going to label each number. So I see as a pH of 7.25, I'm going to label that as acid. Then I'm going to look at my CO2 of 50. Now that's high because I'm going to remember normal CO2 is 35 to 45. Too much CO2 retention causes acidosis. So I'm going to label that CO2 of 50 as acid. And then a normal bicarbonate range is 22 to 26. So a bicarbonate of 25 is just labeled as normal. Next, I'm going to focus right back on that pH, 7.25. Right away, I know that this patient's blood is acidic. We have a problem. We now have a low pH. We have acidosis. So I can begin to work on my correct answer to this problem. We have something, something, acidosis. Now the next step, who made the blood acidic? Who is at fault? So looking at my labels, I can see that the pH and the CO2 are both labeled as an acid. Now that's what I mean by matching. It really means that I have acidosis because of a respiratory issue or respiratory acidosis. So there's another part of my correct answer to this problem. I have something, respiratory acidosis. So the next step is to see if we have compensation. Remember, if we have an abnormal ABG, there's always going to be a cause. And sometimes there might be some kind of help or compensation. So I'm going to go back and look at the number that did not match the pH. And in this case, it's the bicarbonate. And here it's labeled as normal, which means it isn't doing anything. It isn't trying to create an alkaline or a basic environment to try to help bring the pH back to normal. The bicarbonate is just normal. And this can be a little bit tricky because usually normal is a good thing, but in this case, you want to think of it kind of as it's not doing anything. It's not making the problem worse, but it's also not helping. It's not compensating. So all we have here is just regular old respiratory acidosis without compensation. So what we would call it is uncompensated respiratory acidosis. And then last, we always want to evaluate oxygenation. Remember, I already have the correct answer to my problem, but I need to know, is my patient oxygenating okay? That's very important. So you can see here that the PaO2 is between 80 and 100, so this would be labeled normal. So let's look at another example. Now I recommend pausing the presentation and seeing if you can walk yourself through this example on your own before you watch the explanation. So step 1, label each number. pH is acid because it's less than 7.35. CO2 of 39, it falls between 35 and 45, so I'm going to label that as normal. The bicarbonate is 19, which is low. Remember, normal is 22 to 26, so that's enough. Not enough bicarbonate, and low bicarbonate is low base, which is acidosis. So right away, I'm going to look at the pH, and I know my correct answer is going to be something, something acidosis. Who is at fault? Well, which other number is labeled the same as the pH? Well, the bicarbonate is. So that makes this metabolic acidosis. So my correct answer is something metabolic acidosis. To figure out what that something is, I'm going to ask, did the other system try to help? So what's the other system? That's my CO2. Did my lungs try to make a more alkaline or more basic environment to help compensate? Let's look at what the CO2 is labeled. It's just normal, so it did not try to help. So now I know we have uncompensated metabolic acidosis. And then next I'm going to evaluate my oxygenation, which is normal. So we're going to come back to this slide just one more time here. And this is really because it's always important to take a step back and just remind ourselves of what we're looking at when we're doing ABG interpretation. When we're interpreting an arterial blood gas, we're trying to figure out if the patient has a problem and then what the nature of that problem is. So the same broad concepts that could cause a pH to become acidic or alkaline are also the ways that the body tries to compensate. So for example, if I have a pH of, let's say 7.56 because there's too much bicarbonate retention, that's the problem that I have. I have metabolic alkalosis. And my body could try to help itself by using the other system, the respiratory system, to create an acidic environment by hypoventilating and retaining acids to correct that pH. Or we could look at a patient who has metabolic acidosis, let's say because of renal failure. Let's look at how the respiratory system might try to compensate for that. Well, they could create an alkaline environment, the opposite environment, by hyperventilating and blowing off a lot of CO2 to try to bring the pH back up. So you can see how compensation and the disturbance can kind of be illuminated in this slide. Now we're going to walk through all of the possible acid-base disturbances and get a little bit more into how to interpret different types of compensation and different ABG disturbances. So here you can see what we've already really used as an example, the primary uncompensated states. We have a clear problem, so we have either acidosis or alkalosis, and we have a clear system at fault, so either metabolic or respiratory. And then the remaining system that isn't part of the problem is not trying to help. So what we see is an abnormal pH, either acidotic or alkaline, and one system that matches that pH to help us label it as respiratory or metabolic, and then the remaining number that's left over is normal. It's not helping, not compensating, giving it that uncompensated label. So let's look at an example of an uncompensated state. Pause the presentation and work through this ABG. Step 1, we label. So pH of 7.5 is base, CO2 of 43 is normal, bicarbonate of 29 is high, so that's going to be a base. So what's my main problem? I'm going to look at the pH. So I am in something alkalosis. Who is at fault? Which one matches that pH? Which one was also labeled as a base? The bicarbonate is. So we're in metabolic alkalosis. Now, did the lungs try to help? Is my CO2 labeled as the opposite? Is it labeled as acid? Nope, it's just normal. So it's not trying to help, it's not trying to compensate. So we have uncompensated metabolic alkalosis, and my oxygenation looks normal. So now we're going to introduce a new category of acid-base disturbance, and this is called mixed disturbances, or sometimes we call them combined. But what's happening here is we essentially have more than one cause of a problem. So in the case of mixed acidosis, the pH would be acidic, and when I look to see which one matches with it, either the CO2 or the bicarbonate, they both match. They're both labeled acid. So we essentially have respiratory acidosis and metabolic acidosis in the same patient. And rather than saying they have respiratory and metabolic acidosis, we just say they have mixed acidosis. And if you think about it, it makes sense. That's a very sick patient. They could be hypoventilating and have kidney failure, for example. That's a respiratory problem that could cause acidosis and a metabolic problem that could cause acidosis, both happening in the same body, both causing the patient's blood to be acidic. And the same concept is true for mixed alkalosis. We have a patient with respiratory alkalosis and metabolic alkalosis. They're maybe hyperventilating and they have diarrhea. The same person has two alkaline problems, so all the numbers would be labeled base, 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 or all the numbers would be labeled as acid, acid, acid. So no system is trying to help or trying to compensate. They're all causing the problem. So let's look at an example of a mixed arterial blood gas. Pause the presentation and work through this ABG. So step 1, we label. So a pH of 7.3 is acid. CO2 of 60 is high, so that's going to be acid. Bicarbonate of 19 is low, so that's actually also an acid. What's my main problem? Go back to the pH. So I am in something acidosis. Who is at fault? Well, which one matches the pH? My CO2 does, so that's respiratory acidosis, but my bicarbonate also does too, so that's metabolic acidosis. So now I have one problem with two causes. So this is really mixed acidosis. Now, did any system try to help? Well, definitely not, because they were both part of the problem. So we don't say uncompensated mixed acidosis because we understand that if you have mixed acidosis, you can't have compensation. So this would just be mixed acidosis. And then don't forget to evaluate oxygenation again, which in this case is normal. So the next category of acid-base disturbances we'll look at are the partially compensated states. Now, we've alluded to compensation already and how one system could be causing the pH to be abnormal and the other could be trying to help out, but we haven't really seen that yet. So we're going to start seeing it come into action here. So when you look at each of the numbers, the pH, the CO2, and the bicarbonate, they will all be labeled as abnormal, so either acid or base. None of them are going to be labeled as normal. But the key is that one will match the pH and one will be the opposite of the pH. And that one that matches is the problem, and the one that's the opposite is trying to compensate. Now, we call these partially compensated because that compensating system is trying to help, but it hasn't completely helped yet. And how do we know that? Well, we know that it hasn't completely helped or it's only partially compensated because the pH is still abnormal. It's still either below 7.35 or above 7.45. So let's look at an example of a partially compensated ABG. Pause the presentation and try to work through this arterial blood gas. So step 1, we label. So pH of 7.3 is an acid. CO2 of 60, that's high, so that's going to be acid. And bicarbonate of 28, that's high, and that's going to be labeled as a base. Now, what's my main problem? Go back to the pH. So I am in something acidosis. Who is at fault? Well, which one matches the pH? Well, my CO2 does. That's also labeled as acid, so I am in something respiratory acidosis. Now, did any system try to help? Well, I'm going to look at the other number that did not match the pH, the bicarbonate. Is it in the opposite direction of the pH? Well, yes, it is. Our pH was acidic, and our bicarbonate was labeled as basic. So it is trying to help, and we have some type of compensation. So now I can update my answer to compensated respiratory acidosis, but now I have to look to determine what kind of compensation. Well, because my pH is abnormal, it's below 7.35 in this case, my kidneys were trying to help, but they aren't completely done helping yet. We aren't completely compensated. So I only have partially compensated respiratory acidosis. So that would be my final answer. And then always again, check the oxygenation, which again in this case happens to be normal. But again, just keep in mind that that's not going to change the answer or the compensation for this. So the last acid-base disturbance that we're going to talk about is fully compensated states. And this concept is very similar to what you just learned about for partially compensated states. Both the CO2 and bicarbonate are going to be abnormal. One is going to match the pH, telling us whether or not the acidosis or alkalosis is respiratory or metabolic. And then the other number is going to be the opposite of the pH, showing that it's trying to compensate. However, instead of being partial compensation where the pH would be abnormal, below 7.35 or above 7.45, the pH is actually normal now. So we start to apply some new rules for how we label the pH, where now we look at 7.4 as our midpoint reference point. So if the pH were 7.37, let's say, that's a normal pH. But it's between 7.35 and 7.4. So I would label it as normal, but normal acid. And if we had a pH of 7.43, that's also normal, but it's between 7.4 and 7.45. So I would label that as normal base. So we call these fully compensated states because the compensating system has now brought the pH back into normal range. But we can figure out what the core problem is by being just a little bit pickier about that 7.4 range and seeing which side of normal the pH is on. So let's look at an example of a fully compensated ABG. Pause the presentation and work through your answer. So step 1, we label. So the pH is 7.36 is normal, but it's on the acidic side. Remember, it's between 7.35 and 7.4. So I'm going to label it as normal acid. CO2 of 60 is acid. Bicarb of 28 is high, so that's going to be base. So what's my main problem? Look at the pH. Well, it's normal, but it is slightly acidic. So I either just have a normal ABG or I'm in some kind of acidosis. If I have any other abnormal values, though, I know it's not a normal ABG. So looking down, I can see now I have something acidosis. So who is at fault? Which number matches the pH? Well, my CO2 is labeled as an acid and my pH is normal acid, so those match. So I am in something respiratory acidosis. Now, did the other system try to help? So I'm going to look at the other number and see if it did not match the pH, the bicarbonate. And it is in the opposite direction. So our pH is slightly acidic and our bicarbonate was labeled as basic. So it is trying to help out and we have some kind of compensation. So now I can update my answer again. We are in something compensated respiratory acidosis. Now the last question, I have to see if I have full or partial compensation. Well, because my pH is between 7.35 and 7.45, so technically normal, my kidneys have compensated. I have a fully compensated ABG. My pH is normal. So now I know we have fully compensated respiratory acidosis. And then always remember to check that oxygenation, which again in this case is normal and is not going to affect whether or not I have compensation or not. So let's review the idea of compensation. And we can walk through a patient who goes from uncompensated to partially compensated to fully compensated, and that can kind of help you understand somewhat of the slight differences between these states. So looking at this ABG, we can first label. So we have a pH that is an acid, CO2 of 60 that is acid, and bicarb of 24 that is normal. So we're in something acidosis. The CO2 is labeled as an acid and the pH is an acid, so we have something respiratory acidosis. The bicarbonate is normal, so it's not trying to help or do anything, so we have uncompensated respiratory acidosis. Now let's say some time goes by and our kidneys are trying to compensate. So now our bicarbonate would become more alkaline to try to help, right? We have an acid issue, our kidneys are going to try to create a more basic environment. So let's say that the bicarb goes from 24 to 30. Our kidneys are retaining some extra bicarbonate to try to bring the pH back to normal. Now my normal label goes from normal to base for the bicarbonate. Now we still have respiratory acidosis. Those labels didn't change, but we're going to now add in compensation because the bicarbonate is now in the opposite direction of the pH. So we have a compensated respiratory acidosis. Notice that the pH is still abnormal. It's still less than 7.35, so we only have partial compensated. So this new ABG would be partially compensated respiratory acidosis. Now last, what if we had some more time go by and this compensation starts to really work and our pH begins to normalize? Maybe now it's between 7.35 and 7.45. It goes to 7.36, but it's on the acidic side even though it's normal. So we would now label it as normal acid. And now we have a normal but slightly acidic pH, an acidic CO2, and a basic bicarbonate. We have respiratory acidosis and we have compensation, but it's now fully compensated because the pH is now in normal range. It's between 7.35 and 7.45. So hopefully this helps walk you through the concepts of uncompensated, partially compensated, and fully compensated states. Keep in mind, I didn't talk about mixed states because that's kind of a different concept. There's no compensation going on there. There's just two causes of one problem. So just as an FYI, here's an example and a reminder of what that might look like. If our pH was still 7.25 and our CO2 was still acidic, our bicarbonate would have to also be acidic, and then that would be two causes of acidosis or mixed acidosis.